I'm going to talk to you about the process involved in normal swallow. There are 4 stages to the swallow process. Stage 1 is the oral preparatory stage. Before we even get ready for swallow, we need stimuli. Smells of food being prepared, fruit being chopped, the smell of freshly baked bread, for example, or toast coming up out of the toaster, fried onions, bacon, grilled cheese, whatever it is that you would be motivated to eat, that can really help when somebody doesn't feel hungry. To prepare food for swallowing, we need to get food into our mouths. We need hand-eye coordination to load the spoon, load the fork, get it up to our mouths, and then we need to hold the food in the mouth and move it around. All of this is part of the oral prep stage. And then lip control is important, obviously, because we have to hold the food in our mouth while we prepare it. And that takes us on to the oral phase of swallow, that's stage 2. And that's when the food is in the mouth and we're preparing it, we're breaking it down, ready for swallow. For that to be successful, we need good head control, sufficient saliva. We need the awareness of the need to swallow, which we don't always get in elderly or very frail patients. We need to be able to hold that food in our mouth while we break it down. And for all these things, we need the lips, tongue, teeth, cheeks, and the jaws, the mandible, to be neuromotor programmed to work together to break it down. Once the food is broken down into a soft ball or a bolus, it can be swallowed. The swallow isn't triggered until the bolus is right on the back of our tongue. And in order to get ready for swallow, we need to lift our tongue up, push the bolus back against our hard palate, which is the roof of our mouth, and get it ready just to drop down into the esophagus, which is the food tube. And that takes us into stage 3 of the swallow, which is the pharyngeal stage. At this point, a lot of what happens with our clients and a lot of swallow difficulties, this is where they tend to occur. The tongue squeezes the food to the back of the mouth. The soft palate, which is at the back of our hard palate, raises up and shuts off our nasal cavity. And the food is able then to move right down to base of tongue and move down as long as the airway, the trachea, is closed off. And in order for it to be safely closed off, you need your epiglottis, which is the bit on the other side of the base of tongue, to cover over and cover that windpipe, the big pipe at the front of your neck. The windpipe is closed off, stopping us breathing, so we're not able to speak or breathe while we're swallowing, and that completely is covered and protects our airway. Food passes over the top of the trachea, over the top of the epiglottis, which is flapped down, and falls down into the esophagus, which is at the back of our neck. And the pharyngeal walls, lots of constrictors. It's complicated, but there are 25 muscles involved. Some are contracting and some are relaxing to open up the esophagus, which is normally a squashed flat tube, to enable it to open up and let the food go down it. Food is processed automatically by muscles squeezing and taking it down towards the stomach, which leads us into the esophageal stage. Just before I go on to that last stage of swallow, to let you know that the pharyngeal stage is where small droplets of food and fluid can be aspirated. So small drops, instead of going down that esophagus, down the food tube, can flick over and dribble into the trachea. For lots of reasons. These might be posture, positioning of the client. It might be that their epiglottis has flapped back up and not protecting their airway anymore. and it's very common in people with neuromotor programming disorders, degenerative diseases where the muscles and the nerve endings aren't firing so quickly anymore. So motor neuron disease, multiple sclerosis and dementia are some of those, but our clients with learning disability may have a number of those, all working against each other to prevent that safe swallow happening. So we as speech and language therapists have to look at the risk and look at how we minimise it and decrease it. So if that patient swallows or tries to swallow a large lump that they haven't been able to chew and break down, like a Brazil nut or a large lump of carrot, in my experience that's happened, that can get lodged right over the airway, the air tube, and at point of swallow it just gets stuck, and that constitutes a choke, which is something we all worry about, but it happens a lot less often than that slow aspiration, the trickling of droplets into the airway. So stage 4 of the swallow is the esophageal stage, and that's when the food is travelling slowly down the esophagus. It's beyond our control. It's due to autonomic movement. The muscles are working automatically. We can't do anything about that. But there are problems at that stage, particularly in our learning disability clients who may have very poor posture. So in the esophageal stage, you can get dysphagia or swallow problems due to heartburn, acid reflux, occasionally regurgitation if you're not sitting upright enough, and heartburn where you get really sore feelings coming back up from the stomach, or even acid feelings in the mouth. When those problems occur, obviously we might already be involved, but we would refer the patient on to ear, nose and throat, to a specialist who deals with gastric conditions. If you feel that's happening, you can go to your GP and ask for a referral to ENT. So that in a nutshell is the 4 stages of the swallow process.